My name is Danuta Szirmai, and I am a neurologist resident in the National Institute of Mental Health, Neurology, and Neurosurgery. I had 3 projects that I've been working in in the last 3 months. Is assessing the prognostic power of EEG connectivity measures in patients with disorders of consciousness. We have started in 2022 September, and we have submitted the review for internal review. Disorders of consciousness are temporary states on the continuum of consciousness that stretches from coma to the fully conscious state. If they last for more than a month, then they are considered prolonged disorders of consciousness. It's a relatively rare disease, probably because of the difficult follow-up of the patients. But as the health care improves, there are more and more patients who are being treated in. Are you sure that he will not recover? These are the really difficult questions that physicians face, and it's hard to answer these questions since we know that 10–24% of the patients can regain consciousness even after 1 year after the brain injury. And the unknown prognosis can lead to suboptimal treatment and also the withdrawal of the treatment, which is crucial since we know that the death happens in more than half of the cases because of withholding a new treatment for a complication, for example, pneumonia or oral-cystitis. So what can be predicting markers? It can be age, etiology, the complications, the comorbidity of the patient. We can use behavioral scales such as the coma recovery scale revised. We can use EEG markers, spectral connectivity markers or network metrics, and also neuroimaging techniques such as fMRI and PET. Our aim was to quantify the prognostic value of EEG connectivity measures and compare them with the always used clinical measure, the CRSR scale. So our question was if EEG connectivity measures can improve the prognostication of these patients. The population was only adult patients, and we compared the 2 measures. And our hypothesis is that connectivity measures work better than the CRSR scale. We hope that our study will help clinical rehabilitative decision making and also help the communication with the patient's family. We started with above 8,000 articles, or almost 8,000 articles, and at the end we had 5 full-text articles eligible. The outcomes were diagnostic accuracy measures that we were searching for in the articles. These were either AUC values of the EEG measures and the clinical scale, or the sensitivity specificity results, which we could do only for the CRSR score because we had the raw data. This is the main result of our meta-analysis. It's about diagnostic accuracy in the prediction of recovery of the different methods. All in all, 5 articles were included, and all articles contained at least 2 of the outcomes. The effect measure is the RN undercurve, which is the discriminative capacity of a given measure. And we can see that the AUC of connectivity measures is 78%, which means that this technique correctly diagnosed 4 out of 5 patients. Of spectral power is 74%, while of the clinical scale CRSR is 67%. There is a significant difference between the connectivity measures and the clinical scale, but a non-significant difference between power and connectivity. At the top of the plot, I included the discriminative capacity of automated outcome prediction method, which seems superior to all the examined measures. So to conclude, we can say that EEG connectivity methods can be used with good accuracy in prognostication of outcome in patients with disorders of consciousness. However, CRSR score alone should not be used for outcome prediction. And it seems like automated outcome prediction tools, which are comprised of connectivity measures and network metrics, they promise good predictive ability. For practice, it means that the use of EEG is highly recommended besides these clinical scales, and that the initial state of a patient, so the first CRSR score, cannot really determine that outcome. More research is needed in the field, and the repetition of the already existing articles and studies is needed. So we have sent the manuscript to internal review in the beginning of June. We are waiting for some other replies, and I hope that I will be able to send it to language editing still in the end of June. Our aim is to send the article to Progressing Neurobiology. So our second project is assessing the prognostic power of EEG measures in patients with disorder of consciousness. It's another meta-analysis. So for this study, we basically just widened the scope of the previous review, and we aimed to include all the EEG measures, qualitative and quantitative measures too, in the study. We have done the protocol registration, and we have started the article selection. We have now 263 papers for full text selection, which we are still working on. As for the third project, in the last 3 months I had the possibility to join the Como Science group in Liège, Belgium, and they are conducting a big meta-analysis on the neuroimaging and neurophysiological alterations in disorders of consciousness, and I was helping in the neurophysiological part these times. So in disorders of consciousness, it's not only the unknown prognosis that poses difficulties, but also the misdiagnosis of patients can be really high as 38%. The most challenging differentiation is between the unresponsive wakefulness syndrome and the minimally conscious state. And for this reason, there are accurate biomarkers are needed. So they have conducted the systematic research, and they were searching for all resting state EEG markers, and they wanted to compare them between MCS, UVS patients and healthy controls. The population was adult patients only and prolonged disorders of consciousness, and the outcome was the difference between the brain activity. So I've joined them in the part of full text selection, and I've worked together with 3 other referees in this part. We had at the end 34 eligible full texts, and the outcome measure was the standardized main difference between the 3 groups, and we had 3 comparisons. We had above 15 EEG measures on 5 different bands, and that meant that we have more or less 60 measures, 60 forest plots per comparison. That adds up to 180 forest plots. I would just like to highlight the outcomes on the relative power that we found, because as you can see, there are robust differences between the healthy controls and the MCS and UVS patients, so the DOC patients and healthy controls, in the delta, which is on the top of the plot, and the alpha power, but no significant difference in relative theta power between these 2 groups. But if we examine the differences between the 2 patient groups, MCS and UVS patients, we see that the alpha, the delta, and also the theta power differs slightly but significantly between the 2 groups. So as for a small conclusion of the preliminary results, we can say that there are robust differences in EEG signals in delta and alpha measures between the DOC patients and healthy controls. And although the effect is smaller, the alpha, the delta, and also the theta differed between the UVS and the MCS patients. There is an important implication for practice, which is that theta power seems to be a possible biomarker for differentiate between UVS and MCS patients. And as we have seen, that there are many metrics that they only used in a few studies, and there is a really big need of standardization of EEG measures and the methods how they are examined. I didn't do this alone, and there was a big group working on this study, and I want to thank everybody for accepting me in Liège, and also for the translational medicine to make it possible to do my traineeship here. This is the overview of my 3 studies. I hope that I finish my own study and the second study in October, and the Coma Science Group is planning to finish this study by the end of October too. Thank you very much for your attention.